And other tricks that we always have to consider. So, where your appendix gets inflamed, it's not always the whole thing, right? It can be half of it. It can be just the tip. And so this is an example of psoas and iliac vessels. And here's an appendix with normal mucosal wall layering and normal sizes until you get just to the tip, where you lose the definition of the mucosal walls and it gets bigger and you get that halo of inflamed fat around it. And the big problem is when you get used to finding appendices and you find them draped over the psoas and then they drape over the iliac vessels, they often then dive downwards fast, deep here. An edge artifact from them and the vessels and overlying gas makes it really tough to get to that tip point and say, I have conclusively scanned all the way to the tip. But we have some friends to help us out. So it's kind of hard to have an inflamed appendix and not have other areas of the bowel involved, other clues that tell you, oh, I think there's some inflammation going on here, even if I can't find the appendix. Or you're scanning and you're not sure you can find the tip, but then you start looking for all these things, and those can really help you risk stratify the patient. So sonographic McBurney's is not, oh, I press in the right lower quadrant with the probe and the patient's tender. That's just a McBurney's. It's, I'm looking at a thing that I'm convinced is the appendix. And when I push on that thing selectively, as opposed to areas just above or below it, the patient is most tender when I'm pressing on what I think is the appendix. So I've divided the secondary signs into ones that are secondary signs of the appendix itself, and then secondary signs that aren't the appendix itself. And those secondary signs include the sonographic McBurney's, if we're talking about the appendix itself, an appendicolith within it, which is really highly predictive of appendicitis, and hyperemia of the wall. And then surrounding secondary signs, you've got your hot fat or bright mesenteric fat. Mesenteric nodes, anywhere that you've got an infectious inflammatory process in the body, you often will get some nodal reactivity, which is really tricky, right? Because we like to say, oh, I saw mesenteric nodes, it's mesenteric adenitis, and you always have to stop and say that can be a secondary sign of appendicitis. Free fluid, whether that's in little tiny wedges or whether those are larger areas of free fluid, whether they're turbid or they're clear. Focal, or sometimes with perforation, even diffuse ileus. And then collections, simple, complex, organized, unorganized. So let's go through a bunch of things, and you guys tell me what you think. Okay, I've got thickened mesenteric fat, wall hyperemia. What was the other one?
I mean, it's like a
yeah, and then it's something that looks like a circular bowel area within. I'm not big on wall hyperemia, and I'm not sure the primary literature really bears out the fact that it plays that much role in making decisions. But it's something you're going to see in reports and you're going to hear about, so we'll talk about it. For me, nothing in this image is more powerful than that thickened fat lying around the appendix. It can be interesting to try to figure out, is the thickened fat really selectively around the appendix, or is it everywhere? Because let's say you have a case of IBD, where we know that often those kids show up with their terminal ileitis, and it's kind of a history that's like a little bit too long for appendicitis, but not necessarily like 2 weeks. And then things are worse in the last few days, and now they're really tender in the right lower quadrant. And you get an ultrasound, and it's like, your question is, tell me about the appendix, and they're like, diffuse inflammation, including the appendix. So you have to kind of always be a bit skeptical about, well, is it diffuse inflammation in the right lower quadrant, or is it driven by the appendix? And if we were to scan elsewhere and not find as much of this hot fat anywhere except in this halo around the appendix, then that's kind of another piece of the puzzle, as you might say. Okay, let's have people call out any secondary signs they see in primary or secondary signs they see in this clip.
Free fluid.
Yeah, you see that little halo of free fluid that comes up at the end.
Hot fat, no.
Hot fat. Yeah, I think you can argue. Now, at the beginning, you see it's a little bit smaller. As the clip plays out, it gets a little bit bigger as it dives deep. If you were to try to look at this submucosal, the bright halo within, it's kind of like nice and bright at the start, but then there's areas where you lose it, and it kind of fades out, and that's one of those secondary signs that it even fits more in the, is it heading towards perforation direction?
Do you think that's, you'd also get that just from not being at the right angle?
Yeah, absolutely.
I feel like it's just a perpendicularity.
Absolutely. And I think that, like wall hyperemia, the loss of the submucosal layer plays relatively little part in my overall determination of things like, is this appendicitis or is this patient perforated?
I've seen some of the radiology images that they get, which are really nice, where they take it in a longitudinal axis and you can like literally see the whole appendix like a finger, and then there's just that one little portion where it's missing the submucosa, and you're like, oh, I'm convinced that that's, you know, a perforation there. But I think it's hard to get that.
And it also, you start doing more of the ultrasound looking and comparing yourself, the ultrasound findings to the patient. And this idea of like, what is perforation becomes very nebulous, right? There's perforation discovered at surgery for what was assumed to be an uncomplicated appendicitis, which is often like, oh, there's a little wall of, a little rim of pus or a tiny bit of exudate. There's like that kind of micro perforation in a patient that was not overtly peritonitic. And then there's the cases of like, look, this patient for all the world acts and looks perforated. And sometimes those patients can have a very like impressive sonographic exam and sometimes not so much. And we're still just at the beginnings of figuring out like what sonographic and history and physical and lab findings really help you separate those things. Sometimes there's so much hot fat you can barely see the appendix, right? So there's our finger inside. But in teens, in the world long enough to accumulate more mesenteric fat, you can get these really impressive fields of inflamed fat. And this is a shout out to Greg and Katie and Faisal and the fellows who, they really wanted a picture of me in the swimsuit they got me for Christmas. And so I gave them one, but I made sure that I was wearing clothes underneath. And no one was going to get to see my white butt.
If I ever needed a good reason to spread P2 share or P2SK or whatever the hell.
Okay, so what about in this image? Do people see secondary signs? And if so, what secondary signs do they see?
Free fluid, right?
Free fluid and hot fat.
Yeah, free fluid and hot fat. What are these things? Yeah, the inferior epigastric vessels, which you'll get used to seeing in these shots. Nice work, guys. And pocket of free fluid. There's some air in intestine. And there's a little bowel wall with contained non-free fluid bulging up into that area. So this is your right lower quadrant. Have we seen the appendix? Is this a low risk or a high risk exam? Right. So this is a lot of the thinking about how we're going to use right lower quadrant ultrasound as emergency physicians. It's not as a definitive comprehensive radiology test, but as part of the thing we're doing all the time, which is risk stratifying patients. So the fact that you guys can look at this and be like, that's a high risk exam. Well, how does that perform in terms of comparing someone doing that to not using ultrasound at all as a point of care provider. We don't really know yet. Those of us in the field believe that it makes you better, and we got to prove it. We're the beginning of proving some of these things, and I'll show you some of that data.